And Bill Freeman now will discuss anti-VEGF with navigated laser.
Thanks, Peter. So I've been involved with this system also since its inception, and I think we're at the point where we're actually looking at treatment results in diabetics in using clinical trial methodology. This device was first developed in 2008 when anti-VEGF drugs really were not yet the primary treatment for diabetic macular edema. It was approved a couple of years later. At the current time, it is available in the U.S. You can do focal treatments, as you've seen. You can do pan-retinal photocoagulation. You can do angiography on the device, or you can import angiograms or OCTs or other images into it from other devices that you already have. So it's become a very versatile device, and it's really an imaging system. What you see here is our first publication. We looked at the ability to hit microaneurysms and target them, and we found that using the Navilas, you were able to see a lesion on the microaneurysms 91% of the time. This was higher than what I was able to do utilizing conventional slit lamp laser for all the reasons that we know and that have been mentioned by the prior speakers. The current hypothesis and what we're investigating is that this more precise and complete treatment that we can do with the Navilas will lead to better visual results and less need for intravitreal injections in the era of anti-VEGF therapy. So the study that we're conducting at several centers is what we call the CAVNAV study. And we have two groups of patients who we're looking at. The first group are patients with significant macular thickening and reduction of vision. And in those patients, there is an initial course of treatment with anti-VEGF therapy to thin the retina. And following this, the navigated laser is applied in a grid and/or microaneurysm targeted treatment, depending on the clinician's preference. And patients are then observed in this study, and the goal is to see if the laser locks in the treatment effect and reduces the need for further anti-VEGF therapy. And this is the paradigm that you see here. We do retreat the patients if the vision drops even by a line or there's any real increase in thickening, but if the laser has stabilized things, we just observe them. And what we found in this group of 27 eyes, obviously after the anti-VEGF drug, there's an improvement in vision, but then we don't use any more anti-VEGF. We do the laser, and it appears that the vision has stabilized, and that's consistent with the persistent retinal thinning or reduction in edema that's achieved by the laser. So this, the first group of eyes does suggest that one can stop anti-VEGF therapy after you've treated a thin laser, and at least for a fairly long period of time, have a much reduced need for anti-VEGF therapy. Indeed, in the study, there's only a small group of patients that need any additional therapy. At 5 to 6 month interval, 89% of the eyes did not need further anti-VEGF therapy after the initial anti-VEGF and laser therapy. And we're still doing follow-up, but it looks like this effect is persistent. Some patients will recur, but there does appear to be a much lower need for anti-VEGF therapy. So that is the Group 1 study. Now, the Group 2 are patients who have macular edema, may have lipid in the macula threatening the fovea, but the vision is still pretty good. So in those eyes, we're doing primary navigated laser therapy, again, coagulating the microaneurysms, doing grid as needed, and not using anti-VEGF therapy. I think it was David Brown mentioned that in the future you'll be able to see the aneurysms and laser them directly on OCT. We've actually done that study, and we have a paper coming out in the AJO showing that when you hit the aneurysms with the Navilas, they remain occluded for up to a year. That'll be out in the next couple of months. So we treat these patients as monotherapy, and they go right into the navigated laser arm, and then we follow them to see if this prevents or delays the need for anti-VEGF therapy. And these are the results so far out to 9 months. It looks like only 13% of the eyes needed anti-VEGF therapy. The rest remained with good vision, and this does appear to stabilize the retinopathy and potentially prevent or reduce the need for anti-VEGF drugs. And you can see here in all of the eyes in this study, there's almost 60 of them in general in diabetes. You do get an improvement, and that improvement remains stable with much less use of anti-VEGF therapy. So to summarize, the Navilas clearly allows more precise and complete treatment than conventional laser. All of the speakers keep hitting on the same thing. There's incredible comfort with this because it's not the laser that's uncomfortable, which is what I thought. It's that slit lamp beam shining in. The doctor becomes very comfortable because you have a fantastic view of the entire posterior pole, and the device documents exactly where you're treating. The Navilas does appear to offer an effective and durable treatment for diabetic patients with thick maculas, and that's used after your initial anti-VEGF course, which may be 2 or 3 injections. We're seeing stability of visual gains of approximately 11 letters, and those eyes that respond to Avastin seem to require less retreatment after navigated laser therapy than the non-responders. There's a lot that you can do with this laser. It's a totally different approach than what most of you are trained with, and I think after you use this, you'll say, why wasn't this the way laser was developed, and why did we ever use a slit lamp-based laser? This is better in every way. Thank you very much.
So following up on the theme,